In this capture video, we're going to go ahead and take a look at some concepts of oncology. Again, this is meant to be watched prior to class so you can get more out of our in-class instruction and really focus on application of content. We'll begin by talking about normal cell and immune function. It's important to understand that every cell in your body has a predetermined life cycle and function, and that's coded into their DNA. So for example, a liver cell knows it's going to be a liver cell, it knows its life cycle, it knows when it's going to reproduce, and it knows its function. When you have a cell that sustains damage to its DNA, maybe from UV rays or some other carcinogen, a couple things may happen. First of all, if the damage is so severe, that cell can die immediately or within a short period of time, that the damage is kind of, self-contained. The other thing that can happen is the cell can self-repair its own DNA. That happens quite a bit in our body. The third potential thing is that damage in that cell can be replicated, and that damage is then passed on to the daughter cells, and this process continues. So it's important to understand what keeps us from having cancer at all times of our life is really our immune system. It's constantly on surveillance. It's looking for foreign substances. It's looking for anything that is not considered self. And that includes cells with damaged DNA. If it's damaged to the point that the body cannot recognize or identify that cell as self, it's going to be targeted for destruction. So a lot of these abnormal cells are destroyed before they can even really get a foothold and cause a problem. Now with cancer, you have abnormal cell growth. Again, as I mentioned before, cells have a predetermined life cycle. They know when they're supposed to reproduce, they know what they're supposed to do. But cancer cells, you have this abnormal cell growth. So you have a very rapid and atypical cellular division. So it happens much more quickly than it was supposed to. And when the cells divide, they don't just divide into two. They divide very haphazardly. So sometimes they divide into 3, into 4, into 7. And the cells, again, they don't stay within their own border. They don't stay within their own barrier. And they start crossing over and, laying on top of other cells. So it's a very abnormal, atypical cellular growth. The other thing that happens is you have abnormal cellular differentiation. What I mentioned before, a liver cell knows that it's a liver cell and knows what it's supposed to do. That's cell differentiation. With cancer cells, the function of the cell actually changes. It almost reverts back to a fetal type cell that it doesn't know what it's doing. And the appearance of that cell changes as well. If you were to look at them under the microscope, a cancerous liver cell, particularly as the cancer progresses, is going to look less and less like a normal functioning liver cell. Cancer cells also can invade surrounding tissues. I kind of mentioned that a little bit before, where they don't stay within their own barrier, within their own area. They kind of invade other areas. And cancer cells can also metastasize to other areas, distant metastasis away from the primary abnormality. And that happens through the lymph system and the blood vessels. There's a concept called angiogenesis, where when a tumor gets large enough, it actually can grow its own blood vessels to provide its own blood supply to the tumor. And that really causes a problem because it essentially is a feeding line for this tumor to get larger and larger. So the big concept to understand with cancer is that the earlier the diagnosis and the less progressed it is, the better the overall prognosis is going to be for the patient. So let's kind of talk about some health promotion and primary prevention. And if you think back to your foundational content, primary prevention is true prevention. When we talk about secondary prevention, that's more screening and early diagnosis. But let's talk about some primary prevention. So things that we know that we can do to reduce the risk of actually being diagnosed with cancer or the development of cancer cells. And the first thing up is a healthy diet. We know that high levels of fat, high levels of sugar, high levels of salt feed cancer cells. Okay, so a healthier diet low in fat, sugar, and salt is going to be very helpful. We also know that fruit, veggies, and fiber are very helpful, particularly with colorectal cancer, because they all increase peristalsis, which means it decreases the amount of time that stuff is actually moving through your GI tract. Lean proteins are very good. There has been an association with red meats or dark meats with colorectal cancer and some other types of GI cancer. So diet's a huge component. The other thing that's big is maintaining a healthy body weight or BMI. And that's done through diet and also exercise, activity, staying active. Avoiding tobacco and alcohol are huge things. Okay, tobacco puts you at risk for, lung cancer, oral cancers. Alcohol puts you at risk for GI cancers, liver cancer, drug use, needle sharing, unprotected sex. All of those risky lifestyle behaviors are going to put people at risk for developing different types of cancer. Exposure to hazards, whether it be radiation, chemicals, you want to try to limit that as much as possible. When you're at clinical and you're cleaning off your stethoscope after you've been in an isolation room or cleaning off equipment between patients, you really need to be wearing gloves when you're using those cavity wipes, because that is exposure to a chemical. You want to protect your skin and your eyes from UVA and UVB rays, both from the sun and artificial UV sources as well, tanning coffins. Immunizations, particularly ones that help protect you against viruses that may be associated with different types of cancer, hepatitis B, HPV, and supplementation. There's some research out there that supports that vitamin D can be protective against some cancers, as well as supplementation with antioxidants, that they're supposed to neutralize free radicals that can cause cellular damage. From a secondary prevention standpoint, we're looking at screening and early diagnosis. So these things don't necessarily truly reduce your risk of developing cancer, but it's all about screening, finding it. If it's early, let's deal with it, and we have a better prognosis. So mammogram, the current recommendation is annually for women older than 40. Clinical breast exam, again, annual for women older than 40, and at least every 3 years for women 20 to 39 years old. I do want to note that these are women that are at average risk. If there is a family history of breast cancer, these screenings should begin earlier and may be done more frequently. Pap testing gets done every 1 to 3 years based on the individual's risk factors. Fecal occult blood test, we talked about this in the GI unit. That should be done yearly on all adults. Doesn't matter what the age is, all adults. Colonoscopy, first one should be at age 50 and then at least every 10 years after that. Digital rectal exam should be yearly for men 50 plus. Okay, and they can also do the fecal occult blood test with that as well. But that's also to look at prostate issues. Screening for genetic mutations. This is not necessarily a routine thing, but for your patients that have a strong family history, particularly of breast or colorectal cancer, they've identified some gene mutations that are associated with those two types of cancers, and they may do some genetic screening in those cases. Again, not routine, that's very individualized to the patient. And of course, removal of any at-risk tissue to prevent the conversion of cancer. So, talking about inspecting the skin back in the integumentary sensory unit, identifying any atypical moles and getting those removed, removal of any polyps identified during endoscopy, that sort of thing. So continuing with risk factors, couple things we really can't modify. Age. The reality is, as we get older, we're more susceptible to cancer. And that's just simply because we've been exposed to potential carcinogens over a longer period of time. But also our immune system just doesn't function as well as it did when we were younger. Okay? Kind of doubling down on that immune function, anybody that's immunosuppressed is going to be at higher risk for cancer. So people that have autoimmune diseases that are being treated with steroids, or other immune modulators, it helps keep that disease under control because we're trying to chill out the immune system, but that also chills out the immune system's ability to surveil and deal with potentially abnormal cells as well. Chronic irritation and tissue trauma increases the risk. You'll see this with burn patients. Scar tissue is at higher risk for the development of cancer. Patients with GERD that develop that Barrett's esophagus, where you have that constant chemical irritation of the lower part of the esophagus, that puts them at risk for esophageal cancer. Ulcerative colitis and Crohn's disease, that chronic inflammation of the large bowel, is going to put them at higher risk for developing colorectal cancer. We talked about the genetic predisposition. We talked about exposure to chemicals, tobacco, alcohol, UV rays. Do keep in mind air pollution. That can play a huge role in the development of cancer, particularly your respiratory, your lung cancers, and also exposure to radiation. And, we typically think about radiation as a treatment for cancer, and we will talk about that a little bit later. But exposure to radioactive sources, whether it be in the hospital for diagnostics, a healthcare worker, or, potentially occupational if they work around nuclear energy, or unfortunately terrorism as well, where you talk about dirty bombs and things like that. Something to kind of keep in mind, food preservatives. They are chemicals. They're in there. Yes, they're there to preserve food, give it a longer shelf life, but it is the exposure of the body to those chemicals. Viruses and bacteria I mentioned a little bit before. Hepatitis B and HPV are two that are associated with cancers that we do have immunizations for, but Hep C and HIV also increase the risk for cancer. H. pylori increases the risk for gastric cancer, and Epstein-Barr virus, which is associated with mononucleosis, that's also been linked in some cases to your leukemias and lymphomas. So let's talk about diagnosis, staging, and grading. Something to keep in mind that biopsy is the only definitive way to diagnose cancer. Now, don't get me wrong, docs that have been practicing for a long period of time, when they go in there and they look at something surgically or they're palpating and they feel something and characteristics of the patient, they can make a pretty good, accurate diagnosis that it is likely cancer. But the biopsy is going to definitively diagnose it. It's also going to identify the type of cancer, the tissue of origin. So that biopsy is really important. And then we talk about staging and grading, which those are both different ways to look at the cancer and basically give us an idea of how far along is this cancer? How much has it progressed? And that's going to tie in directly to your patient's prognosis. So starting with staging, for your solid tumors, we use the TNM system. Now do keep in mind this is for solid tumors, so you can't, look at leukemia and lymphoma this way. They have a separate staging system. But the TNM stands for tumor, nodes, and metastasis. And the cancer is looked at from those three aspects, and it's evaluated based upon the tumor, the size of the tumor, and its location. So TX refers that it's unable to be staged. TO is the tumor cannot be identified. TIS, that means tumor in situ. That is typically for cervical cancer, where the patient may show some atypical cells, but it's not necessarily cancer yet. That's typically where you see the tumor in situ is with cervical cancer. The T1 through T4 just indicates the size of the tumor as it progressively gets larger. T1 is better than T4. T4 is a larger tumor. From a nodes perspective, we're looking at regional lymph nodes. So again, NX refers to that the node's status cannot be determined. NO means it hasn't progressed any nodes. And then N1 through 3 is going to have increasing number of nodes involved. Metastasis is evaluated the same way. MO is no distal metastasis. and one refers to the fact that there has been some distal metastasis. Grading is a little bit different. This actually looks at the appearance of cells underneath the microscope, so it evaluates cell differentiation. So early cancers, they're abnormal cells, but the cells still tend to be very well differentiated. They look more normal, and those types of cancer cells tend to be growing a little bit more slowly. As the cancer progresses, you're going to get some poor differentiation or even completely undifferentiated. These cells are so out of whack, they don't even look like their tissue of origin, and they tend to grow quickly and spread very quickly. So, the higher the number, the more aggressive the cancer is. Looking at treatment modalities, the treatment's going to focus on removing or destroying the cancer cells or preventing the continued abnormal cell growth and differentiation. So there's multiple treatments for this. Surgical excision, actually physically removing the tumor, or reduction, reducing the bulk of the tumor. In some cases, the tumor is so extensive or there's multiple tumors that they can't even begin to try to remove everything. So they might remove some or debulk some of them, try to reduce their size. I'm not going to spend a whole lot of time talking about surgical excision because it's very similar to every other surgery that your patient has. Their post-op recovery is going to be very similar. Other treatment modalities include radiation, chemotherapy, hormone therapy, and targeted or immunotherapy. Overall, your patient's goal may be a little bit different, and it depends on the prognosis of what their cancer is, where it's staged at, where it's graded. We may be shooting for an overall cure, and that's usually ideally the thing that we want. In rapid growing cancers with cells that have a rapid division, we can usually try to hit for a cure, and we'll be able to know, fairly early on, within about 2-3 years, is this going to be curative? Your book talks about control. There's some cancers that the cells tend to be very slow growing. Breast cancer is an example of this, where the tumor has probably been developing for a long period of time before it's even identified. So those, we're going for a cure, but we kind of call that control because it's going to take longer for us to determine, yes, we've actually beat this thing. And then in some cases, the goal may be palliation. Maybe this patient has so much cancer and it's spread to so many distal spots that realistically a cure is not happening. And we're more looking at keeping the patient comfortable, preserving life, preserving quality of life. So then we look at it from a more palliative perspective. And again, that's going to vary based on the cancer cell type, the location, and the extent. Client-specific factors will also play a role in this as well. Obviously, patient age. If somebody's in their late 80s, early 90s, we may not be as aggressive with treatment. Childbearing desire for our younger patients that are diagnosed with cancer, that's something to kind of keep in mind, because the treatments that we give to kill these cancer cells are going to affect healthy cells as well, including reproduction. Their current state of health, their expected lifespan, those things are all factors that are going to go into what specific treatment is an individual client going to have. So let's talk about radiation therapy. And just a couple general things about radiation. It's the use of radioactive substances. It's used as a localized treatment, and it really targets tissues and it destroys specific cells. So when we talk about side effects, it really depends on the location of the body, the part of the body that's being exposed to the radiation. Kind of think of it as a laser pointer. That's the radiation path, and anything within that path is going to be affected by it. And it depends on how much radiation is being administered on the tissues. We typically see some skin changes, we'll see hair loss at the radiation site, And as a systemic side effect, we tend to see some debilitating fatigue. And we'll talk a little bit more about that in just a while. Most radiation is typically given as a series of small divided doses on a daily basis over a period of time. And the whole idea is to expose these cells over and over and over again to the radiation, that it causes damage, and those cells don't have time to try to repair in between the treatments. Radiation can be given externally, which is known as teletherapy, and that is the radiation type that most people are familiar with. However, it can also be given internally, and another term we use for that is brachytherapy. So let's talk about external radiation first. Again, as I mentioned, it's going to give daily small doses over a time period of several weeks. Okay, very important to understand that the radiation source comes from a machine that is outside the patient's body. So they are not radioactive. What is critical with external therapy is to make sure that the patient is lined up appropriately with the machine, so that radiation is targeted specifically at a pinpoint area. Even a millimeter or a couple millimeters off in any direction can be catastrophic, because that radiation is not going to that site where it needs to go. So in order to do this, your patient will go through a simulation process. They'll actually go in for like a mock treatment. They'll do scans of them, they'll get them positioned, they'll line them up, and they'll actually do tattoo markings on the skin that they will use to be able to line up the patient very quickly for their subsequent treatments. So a couple things. You want to tell the patient they just want to wash with mild soap and water and pat dry over their skin. They do not want to scrub at those tattoo markings. They may need to be darkened as the treatment progresses if they fade, but you don't want to be scrubbing those off. The other thing that's important, not only over the tattoo markings, but over the entire radiation site, is they want to avoid any type of powders, lotions, ointments, deodorants. Typically, patients are given a list of approved products that they can use. They want to wear soft, non-restricting clothing. You want to allow that area to be able to breathe, so cotton that's very loose fitting. And they want to avoid exposing that treatment site to sun or any type of a heat source, because that can exacerbate the skin symptoms that they're going to have. To deal with the fatigue and malaise, you want to teach them to use energy-saving measures. So they're going to need frequent rest periods. Okay, they need to build that into their day. And the thing you have to remember with radiation is that the effects are cumulative. So the first week that they're getting treatment, they might feel pretty good. They're not going to be fatigued. But as they get into week 2, week 3, week 4, those effects are compounded. So they can really, by the end, be extremely exhausted. So they need to be taught to pace themselves. They need to be taught to take frequent rest periods. From a GI perspective, again, this is going to depend on the location of the radiation, but particularly if your patient's having head or neck radiation, they may develop anorexia due to mucositis, so they're getting inflammation of the mouth, xerostomia, which is dry mouth, and they may even develop some difficulty swallowing, so dysphagia. So things you want to think about is to really maximize the nutrition. So you want soft foods that are easy to swallow, easy to chew, high protein. You do not want them expending more energy to eat and take in calories than the calories that they're actually taking in. Okay, you want to be able to gain calories, not lose them. It is recommended to avoid red meat because radiation in the head and neck area often causes taste changes on the tongue. So foods may not taste the way they typically do to you and I. And they also recommend avoiding spicy, salty, and acidic foods. And patients may not tolerate hot foods. So those are things to keep in mind. On the screen now, you can take a look at radiation dermatitis, and this happens again over with the repeated treatments. Initially, the skin will start with blanching, and then it will become erythemic, which you can see on the left, and it's labeled as dry desquamation. So at this point, the skin is still intact. We usually try to use moisturizing lotions on this because we want to keep it moist. We don't want it to break down, but that's kind of where it will start. As we continue with the radiation, this will often progress to what we call moist desquamation, where you're now having the formation of blisters that may open or actual breaks in the skin. And you can see in the picture on the right, it's become much more red, raw, and it's moist. Okay, so with this, your patient may require a dressing. And if you think back to basic foundational wound care principles, if a skin or a wound is dry, you want to add a little bit of moisture. You don't want it too moist, but you need to add a little bit of moisture. If it's a moist wound, I need to use a dressing that's going to have some absorption or a drying effect. Okay, it's kind of like Goldilocks and the Three Bears. I want to get it just right. It can't be too dry, it can't be too moist for that wound to really heal. Internal radiation or brachytherapy is a little bit different, okay? Now, this is an internal radiation. It might be a rod, it might be a seed, some radioactive isotope, but anyway, it's placed close to the target tissue, okay? So when this is inside your patient's body, the client is considered radioactive. Now, there are different levels of internal radiation. There's high dose and low dose, okay? But as an overall concept, I want you to understand that the client's radioactive, their secretions, whether it be urine, whether it be stool, emesis, sweat, anything, is also considered radioactive. So there are special precautions that we take both in the facilities and these patients take at home to deal with their body waste, linens, dressings, or other supplies that are potentially contaminated. In a hospital facility, somebody receiving brachytherapy is going to be in a private room with the door closed. And there should be appropriate signage that indicates the radiation hazard. In high dose internal radiation, they actually have special rooms for this, that the rooms are constructed with some additional lead lining. The door has lead lining. It's a very special type room. All staff who are working with the patient should be wearing a dosimeter film badge, and that is just to track their exposure to radiation. The other thing that you need to think about is typically in nursing, we like continuity of care. We like, the same nurse to be taking care of the patient, consistently. You cannot do that with these types of patients just because of the level of radiation exposure. When you are in the room, you need to be wearing a lead apron, and that lead should always be between you and the patient. There's also typically in the room a lead container with tongs. I think about patients getting brachytherapy for cervical cancer, where it's literally this rod that is inserted in the vagina up by the cervix. If that rod were to fall out, you want to minimize exposure, and that use the tongs to pick it up and put it in the lead container. And then, of course, follow your hazmat radiation exposure protocol. These patients can have visitors, but visits are limited to 30 minutes. And they really need to stay at least 6 feet away from the source. No pregnant visitors, no children visitors, and staff members who may be pregnant may not take care of these patients. The big thing to think about in protecting yourself is the key principles of time, shielding, and distance. Obviously, the more time you spend with the patient, the more radiation exposure there's going to be. You want to use shielding, such as the lead apron, okay, to be able to kind of block that radiation as much as possible. And distance. The closer you are to the radiation source, the more exposure you're going to have. So time management and being efficient is really important, because you need to be able to go in there. Obviously, to assess your patient, you need to be in close proximity with them. So you need to wear the protective garb, but you need to be able to complete your assessment in a very quick, timely manner, get done what you need to get done, and move away from the patient and really out of the room. I do want to mention client positioning. I mentioned cervical cancer before and being treated with brachytherapy. for that in particular, patients are supine. They tend to be more in a lithotomy position because being able to get access to the vagina. So with that, they're going to obviously have issues with urinary and bowel elimination. They're going to need to use a bedpan. So you need to kind of think about that as you're working with your patient. A little bit about hormonal therapy, and the important thing to understand with hormonal therapy is that it is only effective against tumors that are either supported by or suppressed by hormones. Okay, so typically this is going to be your reproductive cancers, some types of breast cancer, some types of prostate cancer, testicular cancer, ovarian cancer, uterine cancer, that sort of thing. Side effects are what you would expect, okay? If we're trying to block estrogen, you're going to see more masculizing effects. If we're trying to, block testosterone, you're going to see feminizing effects. So you need to teach your patient that. The other thing is this will put your patient at severe risk for bone disease and osteoporosis. So increasing the intake of calcium and vitamin D is critical. It also, for estrogen-based therapies, is going to increase the risk of blood clots. So as a nurse, you need to employ and teach patients about ways to reduce their risk. So staying active, using TED hose, in the hospital using the SCDs. And these patients will be monitored periodically through labs, looking at their CBC, looking at their clotting times to see what's going on with potential risk for clots. Calcium levels, that sort of thing. Immunotherapy is something that's a little bit newer. And when I say newer, I'm saying more like in the last, 20, 25 years. But immunotherapy is different than chemotherapy because it targets specific receptors on the cancer cells, which is neat because it's really targeting cancer cells as opposed to targeting all cells and getting that collateral damage. So we tend to see fewer adverse effects. The biggest ones that we tend to use are called cytokines, and basically they help the immune system be able to recognize those cancer cells and use the body's own natural defenses in order to destroy them. Okay, so kind of really enhancing what should be normal function of the immune system. So we use interleukins and interferons. Again, because we're trying to enhance the immune system, sometimes you're going to get some side effects and it's going to go a little bit haywire. Flu-like symptoms are very common. We will typically try to pre-treat them with acetaminophen, keeping them hydrated to try to minimize those effects and how they're feeling. But you want to be watching for edema and fluid volume overload. You want to be watching for altered mental status, peripheral neuropathy, vision, hearing changes, problems with balance and gait, anything that could potentially indicate cerebral edema, okay, or swelling in the brain. Skin rash is common with immunotherapy. You want to teach your patient that. You want to encourage them to avoid sun exposure, avoid swimming, anything that's going to expose them to UV rays and make it a little worse. Other types of immunotherapy you may hear about are colony stimulating factors or growth factors, and we'll talk more about those in class, monoclonal antibodies, and gene therapy. So this is really an area where we've really come a long way, and we're continuing to come a long way with research because we're now able to really target some of those cancer cells more specifically. And chemotherapy. This is pretty common. Most people have heard of chemo, but it's the administration of cytotoxic agents to damage cell DNA and destroy rapidly dividing cells. Okay, rapidly dividing cells. And the difference between this and the immunotherapy that we were just talking about is chemotherapy cannot distinguish between a cancer cell and a healthy cell. So it's going to exert its effects on all cells, okay? And that's why you see the adverse effects that we do. You know, the nausea, the vomiting, the diarrhea, the hair loss. That's why we see that, the immunosuppression, because it's affecting healthy cells as well. There are multiple classifications of chemotherapy agents. They have slightly different mechanisms of action. So you will often see patients on combination protocols. As we begin to look at chemotherapy drugs, we'll mention some classifications, but where I really want you to focus on is the side effects, okay? How to manage those adverse effects, because what you're going to see as you look at the different classifications is they all pretty much have the same adverse effects. There are some that might have something special, and we'll mention that, but they all pretty much have the same adverse effects. To be able to administer chemotherapy, nurses require special training. There's usually a certification course they need to complete, and there's also special precautions for anyone preparing, administering, or disposing of chemotherapy drugs. Okay, this includes pharmacy, nursing, there's special PPE. To give chemotherapy, it might be given orally in a pill form. It might be given what we call intracavitary. So we talked about this a little bit in the GU unit, where they might instill chemotherapy directly into the bladder through like a 3-way irrigation, clamp it off and let it sit in there and dwell, and then drain it out. They can do that, intraperitoneal. They can do that intrathecal. There's so many different intracavitary ways they can give that. And then the other way that you are probably more familiar with that you think about is intravenously. Typically, chemotherapy is going to be given through a central line or a port, simply because these drugs are vesicants. They will damage tissue if there is an infiltration. So if there is an infiltration in a peripheral line, there is a protocol to follow. There are typically antidotes to specific chemo agents, and those would need to be administered and following that protocol. Okay, but that's why we move towards central lines. Now, the problem with a central line or a port is you have a direct portal of entry into their central circulation. So there is a significant increased risk for infection just because of that portal of entry. And then keep in mind that this patient is going to be immunocompromised as well, just because of the effects of the chemotherapy. So sterile technique is a must, okay? Absolute. Sterile technique, PPE, everything. On the screen over in the bottom right-hand corner, you can see a picture of what a port would look like. A port is a central line access. It is surgically implanted, and it lies underneath the skin. So it's actually covered by your patient's skin. So we're using the natural integumentary barrier as a way to kind of prevent infection. That port will then be accessed with a special needle. It's called a Huber needle, and connected to an administration set. So your patient's port only really needs to be accessed during chemotherapy treatments, or they may use it to also draw blood and that sort of thing. But it only needs to be accessed when they need to use it. Otherwise, when it's not accessed, that skin provides a barrier over top of that port. So some complications of chemotherapy, and we will talk much more about this in class, but like with any medication, your patient may have a hypersensitivity or an anaphylactic reaction. Immunosuppression, we mentioned before. So this is going to knock down their white count, both their total white count and their neutrophil count. You'll hear the term nadir, which refers to the period of time where their white blood count is going to be at the lowest. And if you think about the leukocyte life cycle, this is going to happen 10 to 14 days post-chemo. That is when your patient is at highest risk for contracting an infection that can become deadly to them. In addition to suppressing the white cells, it's also going to suppress production of red cells and platelets. So your patient may experience anemia, and they may experience thrombocytopenia. So anemia, if it gets really bad, it can affect their, oxygen transport capacity. So they might get short of breath. They might be very fatigued, very pale. Thrombocytopenia, if I don't have enough platelets, the patient's going to be at risk for bleeding. Alopecia is the loss of hair. And because chemotherapy is typically given systemically, we think about that as the loss of hair on their head. But you can also lose body hair as well. Actually, I have alopecia on there twice. Okay, so both places. Nausea, vomiting, and diarrhea. Again, because your GI cells have a rapid dividing life cycle to begin with, they are really affected by the chemotherapy. So nausea, pretty common, vomiting and diarrhea. We start worrying about fluid volume deficit. So maintaining hydration is going to be very important in these patients. Obviously, that leads to anorexia and potentially malnutrition. So that's kind of a challenge that we have with these patients. The mucositis and the stomatitis, so inflammation of the oral cavity, the first part of the GI tract. You can have the xerostomia. That can also contribute to malnutrition because it makes it very difficult for these patients to eat. Some medications have what we call chemotherapy-induced peripheral neuropathy, where it can cause burning and numbness and tingling in the extremities especially. It can be the hands and fingers and the feet. So typically we think of neuropathy, the first thing that comes to mind is diabetes. If your patient's not diabetic and they're having this, the next thing I think about is, have they had chemotherapy treatment? And the other complications we look at is, long-term effects on the cardiovascular system, the respiratory system, renal, your kidney function, because it has to process and eliminate these chemotherapy drugs, the hepatic system, because your liver has to, again, metabolize these drugs, and also the effect on reproduction. So just some classifications and agents that you're, somewhat familiar with. Again, they have a slightly different mechanism of action, but I don't want you to get tied up in that. Where I really want you to look at is the side effects, the adverse effects, and how we manage patients that are on chemotherapy. So whether you're looking at alkylating agents, the antimetabolites, antimitotics, anti-tumor antibiotics, I can't even say that word, topoisomerase inhibitors, and your miscellaneous agents, take a look at those common side effects. They all have bone marrow suppression. So that is a critical thing that regardless of what type of chemotherapy your patient's getting, we're going to have to deal with. They almost all cause nausea and vomiting. We're going to have to deal with that. There are certain things that may cause cystitis. So you think about Cytoxan and platinol as alkylating agents. Those often will cause severe cystitis and possibly even bleeding in the bladder lining. So we may need to use three-way bladder irrigation. Almost all of them can potentially cause renal and liver toxicity. So again, trying to keep your patient hydrated, monitoring liver and kidney function, really trying to, support their body's functioning. The one thing I do like to mention, under the anti-tumor antibiotics, doxorubicin, adriamycin, that is one of our big gun chemotherapy agents. And that one in particular has cardiac effects where it can cause cardiac toxicity. Your patient can only receive a certain amount of adriamycin over their entire life cycle because of that cardiac and pulmonary damage. So that's one in particular that has some additional effects. Just a little bit on bone marrow transplantation. This is typically used for your hematological cancers, your leukemias, your lymphomas, but also solid tumor cancers that may have been treated with high-dose chemo that then destroyed the bone marrow. So basically what happens with this is they go through a process, but we're going to completely destroy the patient's bone marrow. We're going to use high-dose chemo, high-dose radiation. We're going to completely obliterate it. And that is going to allow us to then infuse healthy stem cells that should make their way to the bone marrow and then resume normal production of your blood cells, your red cells, your white cells, and your platelets. There's different types of bone marrow transplants. Autologous is somebody that donates their own bone marrow before they undergo treatment, and then they're reinfused with their own. Synergenic would be bone marrow from an identical twin. The majority of us do not have an identical twin, so that kind of leaves us out. So most of the time, what you're going to see is an allogenic transplantation, and this is based on what we call an HLA match. So if you hear somebody say, oh, I'm a match to that person with their bone marrow, they've actually looked at specific HLA markers. They look at 6, and they want to get the closest match possible. Okay, the closer the match, the less the risk of rejection. So complications of this, until that new bone marrow, those new cells get into the bone marrow and start producing their own cells, major risk of infection and bleeding, hemorrhage. Of course, you always have the risk of the failure of the stem cells to actually engraft, where we give the stem cells, but they just don't take hold in the bone marrow. So if that's the case, the transplant needs to be repeated. They may develop what we call graft versus host disease, which is essentially rejection. Sometimes this can be managed by upping the dose of their immunosuppressants to try to, chill the immune system out so it doesn't reject the graft. But in some cases, it may reject and the bone marrow transplant may need to be repeated. There is also a complication, potentially liver phlebitis. And this is the development of clots in the actual circulation of the liver. And that can cause some major problems. So just to kind of recap the harvest procedure and the transplant procedure. So you have to understand, when you're talking about bone marrow transplant, you have 2 patients here. You have the donor and you have the recipient. And the donor, for them to give that bone marrow, they're going to aspirate from multiple sites, usually in the iliac crest, the hip bones. It is painful. It is absolutely painful. You cannot anesthetize bone. So typically for like a donor procedure, they're going to be out with general anesthesia. But post-operatively, they are going to have a lot of pain and a lot of discomfort. But you would manage them like any other post-op patient. After they aspirate that marrow, it then goes to the lab where it's processed and cryopreserved, okay, and gets ready for transplantation. So that's the donor piece. On the recipient side, before we can infuse that bone marrow, we have to immediately completely destroy their immune system. If you leave any aspect of their immune system intact, it's going to reject, okay? You want it to be able to accept the new bone marrow cells. So their system is bombarded. High doses of chemo, high doses of radiation, destroying the entire immune system. For the actual transplant, it's no different than an IV infusion or a blood transfusion. Okay, typically done 2 to 3 days after the last chemo treatment. You got to let that stuff process through its system and get out. Otherwise, the chemo would attack those brand new cells. And then after it's infused, it's going to take at least 2 to 4 weeks for that transplanted marrow to really set up in the bones and start producing those white cells, red cells, and platelets. And again, during that time, critically high risk for infection and hemorrhage. We really got to be careful with these patients. They stay in the hospital, in a clean room, in a completely sterile environment during this whole process, the recipient. I want to mention a little bit about altered body image and self-esteem because a cancer diagnosis is devastating on its own. But then to see the effects of surgery, to see the effects of the alopecia, it can just be very demoralizing. And especially your breast cancers, your GYN or your GU cancers, because maybe it's the removal of the breast, the removal of the testicle, or, in cases of penile cancer, severe advanced penile cancer, removal of the penis. That just adds a whole level of psychosocial difficulty to it. So just some kind of things to keep in mind in general. You want to make sure you're addressing the patient's feelings about body image, their level of self-esteem. You want to encourage them to verbalize their concerns and encourage their partner to verbalize concerns because they're dealing with that too. You want to encourage them to remain active in their care, participate in activities and decision making. For the appearance, you want to assist them in selecting and using products, cosmetics, scarves, hair pieces. Some people like to go bald. Some people, that's part of taking the control back. They're so devastated after they get that diagnosis of cancer. They don't have control over anything. But a lot of them make the choice that they're not going to let the chemo take their hair. They're going to take it before the chemo does. And you'll often see patients will go through the process of shaving their own head or cutting their own hair off. Again, it gives them back at least a little semblance of control. But assist them in selecting products that can kind of try to maximize their body image and maximize, the positivity of feeling good about themselves. So you want to promote self-care, but keep in mind, these patients, they're physically and emotionally exhausted, so you may need to assist them. And we'll finish up just by talking about some oncologic emergencies. These are some pretty serious things, and I'll start with septic shock because we talked about the risk for infection, that myelosuppression. When these patients get an infection, it can progress very quickly and it can become deadly really fast. Something that might have you and I moaning about some symptoms or maybe even down for a day or two can literally kill these people. So infection control and protecting them is so important. For these patients, when you put that gown on, when you put that mask and gloves on, it's not to protect you from them. It's to protect them from you because you are a higher risk to them. If you bring in any type of infection, it could be game over for them. Okay. So septic shock results from infection that then progresses to septicemia. So they are now septic. They have a blood infection. And again, the patients that are neutropenic, ones that have leukemia and lymphomas, those are the patients at highest risk for septic shock. Okay. Things that you'll see, altered mental status. Their temp will be abnormal. And usually we think about a fever as indicative of infection, and it can be. But in these patients, because remember, their immune system is not functioning properly, you may see this manifest as a low temperature. Okay. As the shock part progresses, you can see cool, clammy skin. Their output, urine output's going to drop. Their blood pressure's going to tank. Their heart rate's going to go up. Their respiratory rate's going to go up. These are in an effort to try to compensate for everything. But keep in mind, they're not going to be able to compensate forever. So we need to actively treat this and really be aggressive. This can then progress to what we call DIC, or disseminated intravascular coagulation. Which has a very, very high mortality rate. But essentially, DIC is when the clotting cascade is activated. So what happens is the body is developing these microscopic clots, these really tiny clots that will get lodged in the capillary beds. So it causes issues with circulation. But the bigger issue is, as it's making these microscopic clots, it's using up all of the clotting factors, which then puts your patient at risk for massive bleeding or hemorrhage. So this is kind of a catch-22 because sometimes we'll give heparin to try to slow down the body's use of those clotting factors, but then that increases the risk for infection. A lot of times we'll try to treat this with IV fluids, fresh frozen plasma transfusions. But if your patient goes into DIC, it has an extremely high mortality rate. So the biggest thing when you look at things like infection, septic shock, DIC, we got to look at prevention. That is our number one thing we need to look at. And the other thing we look at as an RN, we need to be able to detect this early and start treatment early for your patient to have a chance. Other oncologic emergencies include SIADH, which stands for the Syndrome of Inappropriate Antidiuretic Hormone. basically, this causes the retention of water and fluid in the body, which then dilutes the sodium. So when I say sodium, you say seizures, okay? So you're looking for changes in level of consciousness, seizures in these patients. We're going to be treating this with furosemide. We're going to be treating it with IV fluids, isotonic to hypertonic fluids, to try to get this straightened out. And then the other thing would be to treat the underlying cause. If it's the cancer that's causing it, we need to treat the cancer to try to stop that underlying cause. Hypercalcemia can also happen, which can cause some nausea, vomiting. It can cause short QT interval, which can cause some cardiac dysrhythmias. Also bone pain and kidney stones. So the way we treat this is with fluids. We want to try to flush that extra calcium out of the system. We'll use furosemide, and we'll use phosphates to try to bind to some of that excess calcium. SVC syndrome stands for superior vena cava syndrome. And basically what happens is this is caused by a tumor or a clot, whatever. It's obstructing venous return from the head and neck and the upper body. So what you'll see in these patients is periorbital and facial edema. And I mean like puffed out. And it's just in their face and neck and upper body. So it's something you pick up on. If you see it, it's just extraordinary. Their face will often be red because of all that excess circulation that's having trouble returning to the heart. And they often develop nosebleeds because those blood vessels are so engorged. Treatment of this, very targeted high-dose radiation right at the tumor to relieve the obstruction. And then, of course, treating the underlying cancer. And the last emergency we're going to talk about briefly here is paraneoplastic syndrome. And this basically is where the cancer just stimulates the immune system, and the immune system just goes haywire and begins attacking normal cells as well. And you see this, you can see third spacing with this. It tends to attack neurological functions, so you really want to watch that neuroassessment. Treatment for this is steroids. We're going to give immune factors. We'll use plasmapheresis to try to pull out some of those antibodies, so hopefully the body stops attacking itself. And then, of course, irradiation. But that's a difficult emergency to deal with as well.